What up?
Hey, what up, man?
What is up, Charles?
Well, had a had a chance to recharge my batteries today. I worked all day yesterday and went in Friday night, and so I took the day off just to recharge my
Oh,
batteries. But as luck would have it, I ended up working all day today too. I was getting phone calls nonstop. That's just the name of the game.
comes with the
Can't do nothing.
territory. Comes with the
Yeah,
territory. When you're the big boss man. Yeah,
no, I'm
I
just
took off Friday too, man. I took off Friday just to recharge.
yeah,
Exactly what I did, man. Just never do nothing really.
yeah.
Just relax.
So I just figured, well, today's a day that hopefully I would just kind of close my eyes a little bit and recharge, but never happened. But nobody to blame. There's nothing to blame really. When people depend on, maybe they're confronted with a situation that's new, that doesn't have an answer to, they're always going to reach out to the supervisor, and you do your best. You do your best to help your subordinates, and so nothing happened. In this job, I kind of, I gotta say something. I was kind of negligent in thinking because these workers are so good. They're so good. But I forgot one thing. They are humans as well. And there's still that dangers out there of people that don't want to comply or people that feel like they have a bone to pick. And they'll take it out on the workers. So I gotta make sure that, they're protected. They're protected all the way around. Every shift is protected. And like I used to always people just tell me, hey, they're gonna make one complaint against you. Well, guess what? First, let me live long enough so I can receive the complaint. You heard me. Does me no good, right? So if I'm gonna complain, let me be around to receive the complaint and fight the complaint. How's that? So
Sounds good, man. Sounds good.
those are one of the
Well,
things that.
it's those few knuckleheads, these people that come from the mainland or wherever they come from, and they act like jackasses.
Yeah,
Really put out a bad name for the tourists. Not all of them are bad, and it's not their fault.
true, true.
They we have opened up and they're coming, and you're going to see much more of them in the
Hmm.
upcoming weeks. But it's not their fault. They're coming to get away from their place, and but they don't have to be jackasses. I think that's what I see. For the most part, these people are. I run into them. I run into them daily, and most of them are very respectful.
You know
I
what's
took Paul today. Paul, we went past the airport today, and Paul
yeah.
said, because that's the first time I took him, and he goes, "Wow, bro, I must say, at least everybody wearing their mask in the breezeway or whatever I forget what he called it."
Yeah, the
I said,
concourse lobby.
concourse,
Yeah.
yeah, concourse. And I said, yeah, that's kind of how it is every day. Me and Joe come through here, and um, so I think for the most part, these guys want to be good visitors, but there's some that just don't care, and they think that they're above the local residents. They think that because they spent their money to get here, that they're entitled to talk down to people and to treat people with disrespect. And that's the ones that really should put them in one box and send them to back to where they came from in one UPS box, alive, of course, alive, but just put them in one UPS box and ship them back second day air.
Yeah. Well, you know what I guess you and I was talking off air before we came on, and I guess the problem is that we've talked about this before, and it's the enforcement, right? For everything that comes upon us that rules are set up, you need an enforcement element, correct? So
Hmm.
we lack that right now. There is no enforcement element whatsoever. We can enforce, but number one, we don't have a holding facility at the airport. We don't do transport. We got to rely on the police department. And when they don't take the arrest from us, for whatever reason, then it's uh it's a stalemate at that point. So I compare the situation to this. It's funny how you go to a theater, right? But the law requires that there's a lit sign that says exit, and that exit cannot be blocked. And if it is blocked, there is a citations that issued to the theater owner, right? It happens all
Hmm.
the time. And so that's why when they have really good movies and it's to capacity, the owner has to make sure that no one can be standing by any of the exits to block those exits, right? Nor
Hmm.
can there be anything outside the door leaning against the door to prevent the door from swinging open. That's just how it is. And there's all this enforcement for stuff like that. But yet, when you come to enforcing mandates like wearing a mask, right? Um, having the proper paperwork to get into the state, especially when you start relaxing all of that. Yet, you kind of wonder when it first was done, was it just to blow smoke and let people live in fear? Well, people caught on after a while because they knew really nothing was going to be done. And to me, I think the predicament is that's why we're in the position that we're in now. Hard to enforce because when you put out a set of rules that is all bark and no bite, that's the end result.
Yeah, and
That's,
and the enforcement went away a long time ago.
yeah.
It was interesting. I was watching the news earlier today tonight, and or this morning I think it was, and Blangiardi was on and excited because
Mhm.
Honolulu is opening up. They're just opening up. He seems to think everything is all groovy. But he talked about the enforcement, and he made it very clear. He says, we don't enforce. It's the honor system. There's no way we have the resources. He said he's aware of restaurants at 100% capacity when they're supposed to only have been at 50, but they just don't enforce. And that's the attitude, right? Because in his mind, it's really not about public health and safety, although he said it is. It really is about opening up business and opening up the economy. I watched tonight's news, and they interviewed one of the airline airport personnel. I think it was one of the airline workers at the Honolulu airport, and she said that they have an amazingly high number of visitors arriving at Honolulu International Airport with no accommodations. Uh, what you guys see on Kauai, Charlie, they come in and they're not familiar with the rules. They didn't know that they had to have had a test which is a lie. I mean, they cannot tell me by the time you land on Kauai, you don't know about the test or the
The
vaccine
Roberts, the
protocol.
Roberts screeners make them aware of it. They have to
Yeah,
get
when
through
they
that
land,
screener. Yeah.
right. So, but what I'm saying is that those Honolulu is saying that there's just this very high percentage of them. So now the airport personnel got to go to, or airline personnel got to go scramble and try to find them cheap quarantine accommodations. But do you think those guys are going to stay in that hotel? You think these guys are going to quarantine for 10 days when they came with the so-called knowledge that we didn't have a quarantine in Hawaii? That's bullcrap. I mean, no matter where you book your flight, no matter when you check in at the departure airport, I mean, everyone knows. But these guys they think they're because they're spending the money, they think they're going to come to the good old state of Hawaii where get dumb local people that they're going to get away with it, and they're finding out that they're not. But okay, so they get on a cab or a rental car and they get to their quarantine hotel and they're gone, spreading the aloha and leaving the virus behind when they go back home.
Mhm.
So we'll see. We'll
Well,
see. We'll have a good talk. By the way, tonight we have Dr. Jonathan Dworkin, infectious disease specialist. He'll be on tonight. He's coming on in a few minutes. So yeah, we'll have some fun with him tonight.
one thing everybody got to be prepared for, and they talked about tonight on the 6 o'clock news, because of this manufacturers all taking advantage of. The shortage, the shortage. They talk about the shortage. They're already talking about plate lunches costing anywhere between $15 to $20 a plate lunch because they said there's been a shortage of rice coming from California, so they're gonna pass the cost on. There is a shortage of the recyclables that's needed to make the those biodegradable, you know, uh, plates. They're getting rid of the plastics like the forks and spoons, so they got to contend with that. I mean, it's bad enough when you buy a soda and they got paper straw.
Oh,
You don't notice the soda
oh,
tastes warm. So you know what? I'll tell
oh,
everybody. For me, I carry my metal straw. It's cold to the last drop. You can buy it at Macy's. You can buy it at Costco for, I believe, for 6 straws. I think it's $12. It comes with a brush. You clean them and you take them wherever. And I got that at work because you try to drink from a paper straw, right? It ain't. It's just And I'm sorry, but you get too much tree huggers. That's what
if
they call them,
you,
right?
if you, yeah, exactly what they call it. If you take your time to drink your soda with the paper straw, you're gonna get a little bit of extra particles in your soda because that straw actually breaks down in the soda if you take long time for drink like I do.
The last
It's
time I
nasty.
drank from
It
one of
is
those straw,
nasty.
the last time I drank from the straw, I by the time I was finished, my straw went into one origami, one crane. So I guess it
Yeah,
depends on how hard you want the drink.
yeah, I can't actually for some reason I from baby when I was little, you know the wooden spoons from the little ice cream cups.
Yep.
You know that little I cannot for some reason the texture. I so in a paper straw does the same thing for me. So if they give you a paper straw, I gotta freaking drink them out of the cup, and I hate doing that too because I like drinking my soda with a straw. But no, we
Oh.
gotta go with paper straws. Come
And
on.
some people they get a hard time drinking from the cup. Because for some reason when they tilt the cup, their nose actually go into the liquid and they drown. I had a couple of cases investigated. A couple guys they drown from drinking soda from a cup.
That's people like me, Charles, with this long nose.
Ink ka-dink ka-doo, ka-dink ka-dink. You remember that guy Jimmy the Rent?
Uh, Jimmy Durante. Oh
Stop the
yes.
music! Stop the music!
Oh,
Yeah.
our guest has. Oh, I'm showing a low Wi-Fi signal from our guest. Oh. Let's. Oh, it's back. It's high
Oh.
now. It's high. Oh.
Uh
You
oh.
guys seeing me?
Yeah, I can. We can hear you fine. You're a little jerky on the video. Actually, you're frozen. Oh, there we go.
So I see what his what's your DPI on your
Uh,
resolution?
he he has no Wi-Fi. His Wi-Fi signal is going in and out.
Oh.
Oh. Yeah, he's up there on the big island, in the land of the Koki frogs.
Yep.
Yeah, yeah. His Wi-Fi is not functioning.
Uh oh.
Oh. Okay, we're gonna have to fix that, Doc. I don't know if he can hear us. We cannot even hear him anymore.
Well, maybe I
Let's
thought he
see.
was just mad at us and he was staring at us for some reason, but
I
it's
know. Look, yeah,
frozen.
like yeah, the stare down. Yeah, check the stare down. Look,
Yeah.
did you see? No, no. His Wi-Fi is. I have great Wi-Fi on the Big Island. Wonder where he stay. I don't know where he stay. I
I
have no
wonder if
idea
he's
where
up.
he's at, but he'll
I
be
wonder if
back. He
he's
gonna
up in
probably
Waimea
he'll
area.
reset. Hopefully
Yeah.
he'll reset his router and. But anyway, Doctor Dworkin will be on tonight. Infectious disease specialist. I know there's some people out there that think we listen to the wrong people. Doctor Dworkin, physician, infectious disease specialist, author, and an all around good guy.
Yeah, he
and he's
deals
he's
with
on
it, man.
tonight
He deals
every
with it
day.
every day. So, I
Yeah,
mean,
he'll be back.
how
Hang
can
on.
you refute it that's actually dealing with it every day, right?
If you're getting paid off by special interests,
Mm.
then it's real easy to discount what these experts are saying. I really was looking forward to tonight because I want to hear his take on what's going on with Hawaii right now, opening up. Honolulu, you guys are. I pray for you folks. Oahu, I pray for you folks. I sincerely hope that I'm wrong, but I am worried about Honolulu and all the islands because it'll obviously filter to all the islands. But you know, when I see the speed at which Honolulu is opening up, even though we have 150, 160 cases a day, we had 20 deaths in 48 hours. It doesn't phase them. The number of people dying, the
Wow.
number of families affected, doesn't phase them. They're just so excited to get 9,000 people at the UH Stadium. They're excited to open up the marathon. They're excited that all the restaurants and bars are going to be able to serve booze till 2 a.m. now. That's the thing. That's what they're excited about. So, all right, now we know it's real because I heard the koki. I heard the koki.
You never know here, man. Sometimes it works, and sometimes the macadamia nut tree just blows in the wind, and that's it. Your Wi-Fi's gone.
Wow. I'm glad you can make it. We're gonna have to try to squeeze as much in quickly, so in case we get some internet issues. Welcome back, Doc. I know you've been very, very, very busy all around the place, and appreciate you
Thanks for
spending
having
some
me.
time with us. Yeah, wow. I don't even know where to begin, but let's just start with what are you seeing? What are you? Oh, you got one of them too. You got a dog too?
It's Paulo. It's conspiring against us tonight.
Oh,
We'll,
okay, okay.
we'll do our best. I got my crew working on it. Um, yeah,
November
we
3rd. November 3rd is the day, right? We're opening up. Everything is. It's like the virus is gone. Mayor Blanche already said it's an endemic. It's no longer a pandemic. And what's your feeling on all of this, Doc?
Yeah. So, in terms of what we're seeing, it was it was quite a wave, as you guys know, in August and September, and the hospital. It was pretty brutal. I may have mentioned the last time I was on, but our peak day we were at about 50% occupancy of the hospital was COVID, and 100% of our small ICU was COVID. I think Queens Punch Bowl peaked out at about 150 admits or more, actually, with a couple of ICUs filled. So that has melted away pretty dramatically. And what I'm seeing now is sort of a slow simmer, where at any given time here in Waimea, we've got, you know, 2 or 3 patients in the hospital. Some days, 1 patient in the hospital. This is a small hospital. Punch Bowl's been more in the range of 20 to 30, I want to say. So it's a fraction of what it was when it was at peak, but it hasn't completely gone away either. And if you compare this to our first wave, all the way back in April of 2020, it's actually our slow simmer now is as big as our first wave was at the very beginning of the pandemic. So, one big question for me has been: is this just the new normal, or are we endemic? Are we in a state where this is the way it's going to be from now on? And I think the jury is still out on that. We're still trying to determine that. But to get at the question of reopening, a lot depends on that, right? I mean, how many non-immune people are there in our population? What is the potential for this to blow up on us again? What is the potential mortality event if we do things like unmask? And I don't think we're going to know until it happens, but I'm concerned that we still have a large number of non-immune people in our state, and that the potential is there for us to have additional waves. And I personally, this is just a hunch, but I don't think we're at that pseudo happy state of endemicity where everyone's immune and we still have a smoldering of cases, but they're all, or the vast majority of them are relatively mild. I don't think we're quite there yet. We still have a large non-immune population in children, and we still have tens of thousands of adults that I suspect are non-immune based on the vaccination numbers and the case numbers that we've seen.
And also those many of us that had taken the vaccine early on, and with the waning of these vaccines, it seems like the vulnerable community, unless everyone gets a booster, everyone gets their shots. I mean, there's still going to be some level of vulnerability for our population because, like you said,
Yeah.
what is the truth of immunity across the state?
A lot of this depends on how we define success, you know? So if we define success as no cases, I think we're going to be disappointed because there's going to be cases even if we handle the vaccination issue perfectly, right? However, if you define success as people aren't getting very ill, then I think we can do a lot better. And what I mean by that is like, if you look at who's having severe breakthrough cases, you can define that population. You can look at the total number of breakthrough cases that have happened in the country, and you can look at the subset of those that have been severe, and you can pin down who is getting severe breakthrough infections. And if you look at that, what you find is a lot of that is in the elderly, and it's with people who have comorbid conditions that essentially make them immune compromised. So those are the people who really need a boost, I think, most urgently. If you see boosting as we're just going to top off the antibodies so that we avoid all mild infections, well, then we need to boost everybody, right? But most of those people who are younger, who are healthier, even if they get a breakthrough infection, it's going to be a relatively mild infection. So we don't necessarily need to boost everybody. I think we need to define very clearly who's the most vulnerable group and make sure that we boost those people.
Solid.
Yeah.
Hey, Doc, let me ask you. We were discussing prior to you coming on. It seems evident that there seems to be more that just doesn't want to follow rules anymore. That seems to be a big problem that's causing, and so that causing a lot of the mess, right? So what we're doing is we're hoping that people are getting vaccinated. We hope that those who are vaccinated hold true to the social distancing, wearing the mask, and all of that. What do you think about those who not play by the rules? How much more do you think we'll probably see infected people going to the hospitals? I mean, you working at an emergency room? Do you get a feel or a sense that there may be more coming down the road there?
Yeah, that's why I'm a little bit concerned, and I don't think we're quite in endemicity yet. I'm still seeing most of the severe COVID that I'm seeing coming into the hospital now is still unvaccinated adults. And when I talk to my colleagues at Queen's Punch Bowl, that's what they're seeing too. They're still seeing, predominantly unvaccinated adults. We are seeing some severe breakthrough in vaccinated, and what you would expect if the vaccine works is that the total number of hospitalizations would drop as the vaccination rate goes up, but that the proportion of people who are sick and vaccinated would go up because you're running out of people who are unvaccinated, right? So we are beginning to see a little bit of that. And what we're seeing, when we've seen some breakthrough severe COVID, the ones I've seen have been either elderly and frail, often with a remote vaccination, more than 6 months ago, or they've just been very immunocompromised and they probably didn't mount a response to the vaccine in the first place. When I talk to my colleagues at Punch Bowl, they're seeing that type of stuff. And when they're seeing severe breakthrough, it tends to be in those groups. We are seeing a little bit more severe breakthrough with Johnson & Johnson, which is disappointing, people who got one shot, than with the other vaccines. So, but the majority that we're seeing that are severe, the vast majority are still unvaccinated. And that's what I'm seeing here, which makes me think that population is still substantial. And we're trying to pin down exactly how many there are. So if you look at the vaccine data, I think there's close to 400,000 people that are not fully vaccinated in Hawaii, and there's like close to 300,000 that are completely unvaccinated, that had a single shot. And the majority of that is kids. So what you're left with is about 70 to 80,000 adults that are completely unvaccinated. And then some proportion of those people have been infected. Probably a higher proportion of that population than the general population has been infected. But that still leaves most likely tens of thousands of adults, and I suspect more than 100,000 kids that are totally not immune. And that's enough that we're going to continue to see cases. And And what I suspect is that it's enough that it'll smolder along, and then if it hits a pocket of unvaccinated people, a community of unvaccinated people, because these people tend to cluster. They tend to respond to the peer pressure around you or the family dynamics around you. So they're not interspersed equally through the population. They're in clusters. So then you'll see these eruptions as those clusters get infected. For people who have some immunity, who have been vaccinated and who have waning immunity, we really need to focus like a laser beam on who's high risk, right? Because if you get a breakthrough infection, but it's a cold, and you're asymptomatic or you're barely symptomatic, but you're not very sick, that's not fundamentally different than a lot of other circulating viral illnesses. We don't need to worry so much about those people. And one of the things that we're beginning to differentiate with, and this is something that the basic immunologists have been working on very hard over the last several months, is looking at what parts of immunity correlate with protection against severe disease and what parts of immunity correlate with protection against any disease. And what we're finding is with coronavirus, and this is true for other infections as well, the antibody response, when your antibodies are real high after a natural infection or after a vaccine, you're protected for a time against any reinfection. But over time, your antibody levels begin to drop, and your body has a hard time maintaining extremely high antibody levels against everything it encounters. So the antibody level will drop with time. But what we're finding with vaccinated people is that they have memory B cells and memory T cells, other parts of their immune system that work well, that are still online, and actually can learn. So when you get your second shot, or for people who are getting boosted, when you get your third shot, you actually generate smarter memory cells. And those cells, even though they're not cranking out antibody all the time, they're there. And then when you get reinfected, when you get your breakthrough case, they can turn on very quickly. And one analogy that I heard, I believe it was from Shane Karate, who's an immunologist in La Jolla, is that it's kind of like having a factory where the lights are off. But then when you need to make the antibody, the lights turn back on and that factory begins cranking out the antibodies. So people who have been vaccinated, or people who have been naturally infected and then received a vaccine after that, we think have very good memory B cell and memory T cell responses. So they're going to be able to generate those protective antibodies. And this is why a breakthrough case in a person like that is not particularly concerning. What we worry about is a severe breakthrough case, and that's the population that's more immune compromised or that's more elderly. Those people probably do need to get boosted to be fully protected. So what I'm doing as a clinical ID guy is I'm going through my patient population. I'm talking to people one at a time, and I'm trying to identify, well, what are your risk factors? Okay, you're elderly, so we should probably make sure you get a third shot before the winter. Not because I want to top off your antibody levels and protect you against mild infection, but because I want to make sure that you've got that B cell, T cell response, that memory B cell and T cell response that's going to protect you against severe infection. I'm much more interested in that than I am in what the actual antibody level is. So that's the way I'm starting to think about it. And I think that's probably going to be the paradigm going forward. What we're really interested in is protecting people against severe disease. And to the extent that we're in trouble, it's because we still have a large number of people who are not protected against severe disease.
Quick question for you, Doc. It's up on the screen. I think it's perfect timing.
Yeah. What is the immunity for a person who has recovered from COVID versus a person who is vaccinated? Are they at an advantage for natural immunity since they have developed antigens? So, yeah, this is a hot topic right now, and it's a good question. Natural immunity is good. We think it gives most people a memory B cell and T cell response. It certainly gives them an antibody level for a while. They're protected for at least a few months. The problem with natural immunity is that it's somewhat variable, right? And if you think about it, that makes sense logically, right? If you're infected, you may get a big dose of inoculum when you're infected, or you may get a small dose. You may have a severe infection, or you may have a mild infection. It's not standardized in any way. So some people get really excellent immune responses from a natural infection, and other people, particularly people who may have been very mildly ill or asymptomatic, may not get a very good immune response to the infection. So there's a lot of variability packed into that. And some of the data that Shane Karate, who I mentioned before, presented was that if you get vaccinated after your natural infection, even just one vaccine actually, it's much better. It's much better, and that those people may be amongst the best protected. So what I've been telling to my patients who are naturally infected and haven't been vaccinated, and at this point, this is a pretty tough crowd. These are people who have held out for a long time and not wanted to get the vaccine. But I'll see them, and I'm talking to them, and I say, look, you got infected. But if you even get one shot, you're going to be in much better shape going forward. You don't need to get this sick again, right? So that's what I'm trying to encourage, and I think those people are actually going to be okay once they get through the initial infection. The problem is getting naturally infected is a dangerous way to get your immunity, because you may get really sick, you may get long COVID, you may get other problems.
Okay, thank you.
Yeah.
Well, then let me ask you, in correlation with the flu season, because it appears from everything that I've read with regards to COVID and the amount of damage that it's done, even the slight amount of damage that it's doing, um, when the flu season is upon us, which it is, I believe it's now, uh, does it increases the severity if they come down with the flu?
Yeah, I don't know yet, because I haven't seen a co-infection yet. We're gonna find out. That's the fear. Is and there is precedent for this. When we first got these multiplex PCR tests that allow you to test for lots of different respiratory pathogens, what we began to find was that people coming into the hospital with respiratory symptoms that were bad enough to get them hospitalized oftentimes had more than one thing going on. So in the old days, all we had was culture, right? We try to get somebody to cough up some sputum, and we'd send it to the lab and look at it with the microscope and try to grow it. And we would either find a bacteria or not. But for the last 10 to 12 years or so, there have been widely available these multiplex tests. So we just get a little swab, and we can send it for molecular testing for like 20 different things. So we really know, what's in somebody's nose when they come in with a symptom now, right? We can pin that down very, very precisely. And it's common to find more than one thing. And then the question is, okay, well, what's driving it? And what's the interaction between those things? And I think our understanding of that in terms of infectious disease and immunology is still fairly primitive, because these tests have only been widely available now for about 10 years. And last year, as you guys recall, the flu season was like wiped out by all the mitigation stuff we were doing for COVID. So there's a fear that we're going to see really bad stuff with COVID and influenza co-infection. And we might. It's also possible that if we continue to do indoor masking, and if we have a high rate of uptake with the flu vaccine, that we mostly dodge the flu bullet and end up dealing predominantly with COVID. So I'm taking it seriously, but I don't know yet, because we haven't gotten there. And what I've been doing is, at the same time that I'm having the booster conversation with everybody, I'm also having the get your flu shot conversation. So I think we got to do both. The flu shot, of course, is a kind of crummy vaccine. I don't know if you've had anybody on to talk about this, but even during a good year, it's about 50%. It's not great. But the way I think about the flu shot is it's like a seatbelt. The seatbelt's about 50%, right? You wear your seatbelt when you drive around, because if the car crashes, you don't want to be thrown through the window. You're happy to have that 50%, right? And that's kind of how I think of a flu vaccine. It's not perfect, and you may get the flu anyway, but you're probably going to have a more mild case. And so it's partly protective. And given what's going on right now, I think it's the smart thing to do, especially for older folks.
All right, another viewer question, Dr. Dworkin. Should a male young adult with G6PD take the booster shot? I have no clue what the heck G6PD is.
Yeah, I'm not aware of any specific precautions with that condition or with any other metabolic or immune conditions. I'd have to do a literature search to see if there's been any specific problem with G6PD, but I have not heard of anything about that.
Okay. Hey, Doc, someone wants you to comment on, after you take this question, but someone wants you to comment on the Delta 2, if you have any
Okay.
knowledge on that.
Should I do the boosters? We got boosters 4 months ago. Are we eligible for fourth shot? The only thing I've heard for fourth shots has to do with people who are highly immune compromised. And this came up for me recently, fairly controversially, because there are patients who got vaccinated last year, who got their two mRNA shots, but were extremely immune compromised while they got their shots. and essentially didn't react to those shots. And so for example, I'll give a common example. Let's say you're a patient who was getting chemotherapy during the COVID epidemic, right? There are these people, of course, and they got their vaccines because they wanted to be protected if they could be, but the vaccines probably didn't do much, right? And now they're done chemotherapy, and they're like, "What? I just get a third shot? Why can't I just repeat the 2 shots, right?" Which technically would get you to a 4th shot. And the thinking on this is that it's probably legit just to revaccinate those people, to give them a 3rd shot and then give them a 4th shot and act like they never got vaccinated. And we've done this with other infections. Like if you get your bone marrow wiped out from stem cell transplant or something, we repeat your primary series of vaccinations for a number of conditions. So there may be people who end up getting more than just 1 booster, but those would be very special circumstances where somebody is particularly immune compromised and probably didn't respond at all. And there is a little blurb on the CDC website now that says you can do that with some specific instructions. I think it's wait 6 months after the 3rd shot was the latest I saw. But we're talking about a fairly small number of people for that. Delta sub lineages. Okay, this is a hot topic. So now everything's Delta, right? Which means that the future stuff we're going to see is most likely going to be descended from Delta. And sure enough, there are some Delta sublineages that have been described around the world. There's one circulating in the UK right now that's gotten a lot of attention that may be somewhat more transmissible than Delta itself. And as has been the case with all the other lineages, I'm just kind of waiting to see what the data is. I mean, this has been coming up ever since Alpha, right? So we've been talking about this now for like 11 months, guys, right? Where there's a new lineage that comes up, or there's a new subtype, and I wait to see the transmissibility data, and I wait to see what the vaccine escape issues are. It would have to be really good to be better than Delta, and even if it's 10% or 20% more transmissible than Delta, I wouldn't worry over much about that. I would still basically stick to the same strategy of saying we got to get a very high number of people vaccinated. What would be really concerning is something that is completely different and that escapes immunity entirely. And we're not seeing that so far with Delta sublineages. So as far as I'm concerned, it's still the Delta world. And if there's some Delta family members beginning to float around, that's what you'd expect. And I haven't seen anything that would dramatically upend that paradigm. The thing that I would worry about again would be if there's some gigantic recombination event, like COVID recombining with another virus, another coronavirus, say, and really fundamentally changing the way it behaves. That would be sort of the worst case scenario. And knock on wood, we're not seeing that right now. The other thing to consider as a possibility is that the virus still has to bind to that ACE receptor in our respiratory cells in order to get into our body, right? So when it changes, it may be more resistant to our antibodies, or it may be more contagious. But if it changes so much that it can't bind to our respiratory cells, then at some point it doesn't work anymore. It runs out of evolutionary runway is sort of the metaphor that I'm thinking of. And we don't know exactly how long the evolutionary runway is for coronavirus, for COVID. For some viruses, it's quite long. So influenza is an example of a virus that can change quite a bit each year and escape vaccine immunity and yet still infect us. But for other pathogens, that's not the case. And there's a fitness cost to mutating beyond a certain point that makes them not as good at infecting us. So that may be a point of optimism, and we just have to see where this shakes out in terms of COVID. But just to give one example of that, that I like to give, and it's not even a virus, so it's not a perfect example. But when I used to do antibiotic stewardship at Queen's Punch Bowl, a lot of what I did was worked on antibiotic resistance issues with bacteria. And we were trying to make the hospital safer in terms of antibiotic resistance by using antibiotics in a way that wasn't going to drive up resistance. And one of the observations that I thought was interesting was some bacteria are very good at evolving resistance to antibiotics, right? So if you think about MRSA, methicillin-resistant Staph aureus, staph infections are nasty. And almost as soon as penicillin became widespread in the world, Staph aureus evolved penicillin resistance. And now 80 to 90% of Staph aureus that you encounter is penicillin resistant, right? Strep, on the other hand, is still almost 100% penicillin sensitive, even though penicillins have been around now for Well, they were discovered in the 1920s and they were widely used in the 1940s. So we're approaching like a century. And that thing, for whatever reason, it can't evolve efficient penicillin resistance without not being able to do the things it needs to do. So there's a metabolic cost to making yourself more resistant. And different pathogens have different thresholds for that. And one of the big hot debates in COVID right now is where is that? Is it going to be easy for it to evolve vaccine escape, or is it going to run out of runway? And that's not going to work for it. And we don't know. But I'm hoping, and I'm guardedly optimistic that it can evolve more, but that it's still going to have to bind to that receptor, and therefore we're going to see at least some effectiveness from the vaccines, or with mild modifications to the vaccines.
Okay.
Wow, I feel like I'm back in school. Yeah, Aaron asking about the J&J. CVS, I just made my reservation or appointment with CVS for the J&J. Yeah, just go on the CVS website or check with your doctor. But CVS, you can get it. It's free. You'll get a Moderna booster for your J&J. And
Yeah.
they don't require there's no age limit or whatever. You just go on there, fill up the thing online, and get your date and time. In fact, they're wide open. So
J&J, I saw Fauci on television talking about J&J, and as you guys know now, they're talking about a second shot for J&J, more so than for all the other shots. For Pfizer, for Moderna, it's only the high risk people that need an extra shot. Whereas for J&J, they're recommending a second shot for everybody. And I have to say, I was a little disappointed by the communication around that. The whole thing was presented as a one and done shot, And I've been on your show and I've described it as a one and done shot based on all the data that was presented up until a couple of months, up until about the last month or so, right? And then we had this VA study that came out that showed dropping efficacy. And we had some data from New York State Health Department showing dropping efficacy. And these guys, they went on TV and they said, well, it's always been a 2-shot vaccine. And I just want to flag that because I think it's terrible public health communication. If the plan needs to change because things didn't work out the way we were hoping they would work out, that's fine, but let's at least own it, okay? We thought it was a 1-shot vaccine. It turns out we were wrong, and it's looking like it's going to be a 2-shot vaccine. And not only that, but it's better if the second shot is a different vaccine than the J&J. So J&J is a perfectly good first shot, but then you should follow it with a Pfizer or Moderna. And that's a change in strategy from where we were just a month ago. And frankly, it's a disappointment because the allure of J&J was the one and done. Now, that said, the data I've seen on it, its efficacy against severe disease, it was not as good with 1 shot as those other 2-shot regimens, but it was still 80%, at least in the New York State data. So it was still pretty good. But if you're going to do the J&J now, I'm telling people you got to follow it up, most likely with an mRNA. If you really hate the mRNA vaccines because you've got some ideological reason, you can get a second J&J. But it's a 2-shot series.
yeah, that's why I got the J&J, because you told me it was a 1-shot deal, Doc.
I know. I misled everybody. I'm sorry. I feel annoyed by it because part of the slipperiness of some of our federal public health communication has been they don't acknowledge when they're wrong about stuff, right? And this came up with masking too. They were telling everybody, oh no, you don't need a mask. It probably doesn't work. And then it turns out they were wrong. It does work. So they changed their tune on it, but they kind of act like they weren't changing their tune. Oh, well, our thinking was this and now it's this. Just own it when you're wrong. It's so basic to building trust with people. And, it's impossible to be right about everything, but I can't stand it when they act like they didn't change what they were saying. Of course, we all noticed it, right?
I see that in our state level as well, not just the national level. Our state is famous for that. They will refuse to come out and say they misspoke. They just gonna play it off like they never said it.
Right. I mean, it's poisonous to getting people to trust you, right?
Exactly.
Okay, we have a question here. I'll read it off of the screen. It's from Darren Rosa-Pozo. He says, how can a family, there you go, here on Kauai catch COVID twice? How can a family in Arizona lose 5 family members, which 3 were fully vaccinated? How can Ireland have a 91% vaccination rate, but has the highest numbers of COVID patients in hospitals? in 7
Yeah. So
months. Yeah.
I haven't looked at Ireland's data lately. Um, you know, can someone who's fully vaccinated get severely ill from COVID? Yes, they can. Um, Absolutely. Uh, Usually there's something going on. The cases that we've seen with that are people who are medically frail and who probably need to get a third shot. Um, if you look around the world, countries that are well vaccinated are doing better than countries that are not well vaccinated, and you need to look no further than India, right? So it's not that India had I think 3% vaccination when Delta hit, and just this mass mortality event during Delta wave. We think millions of people died, and they couldn't even count them. They were dying so fast. They couldn't count cases or deaths. So I look at other countries, and there are examples of countries that are highly vaccinated where there's still a lot of cases, but most of the countries that are highly vaccinated have dissociated the mortality curve from the case curve. So we saw this in Western Europe quite a bit over the last couple of months, where they hit a vaccine rate of 70 to 80%, say, and they're still having cases, but hospitalizations are going down. Why is that? Well, first of all, there's waning immunity. So your antibody level drops, but remember we were talking, you still have memory B cells and T cells. So you're going to see case numbers go up as immunity drops. But assuming that the person is not elderly, frail, or immune compromised, they're still going to be protected against severe disease. So you start to see disassociation between case counts and hospitalizations and deaths. That did not happen as much in the United States. If you look at the United States, and one simple way to do this, if you guys want to see if I'm right, is do some Google searches, look at Reuters COVID data for various countries, and look at case curves, look at death curves, and look at the vaccination rates in the various countries. And if you play that game, one of the patterns you'll begin to see is that in countries where the vaccine rate is higher, which includes places like mostly in Northwest Europe and in Canada, what you'll see is that there's this dissociation. So you'll see cases going up when Delta hits, but hospitalizations and deaths not going up as quickly. If you look at the United States, you see that there's still a lot of close tracking. We're still at 1,000 deaths a day in the United States, and our vaccination rate is like in the 50s nationwide. We're now, I think, 54th or something in the world in vaccination. So I mean, you can try to find it. You can always find examples of where the vaccine fails, particularly if the person is sick for some other reason. But I think the epidemiologic trend is pretty clear. Higher vaccinated places are doing better than poorly vaccinated places. And when your R is 6 to 8, i.e., in other words, when you've got a virus that's this contagious, 50 to 60% vaccinated is not going to cut it. You're going to have a lot of vulnerable, non-immune people that are falling ill. And that's what we're seeing in the United States, in community after community after community.
All right. The questions are coming, Doc. I hope you don't mind. This is like, can a person who had a mini stroke be vaccinated? Does he have an excuse for not being vaccinated?
No, I don't think
And
stroke is.
Doc, I always say this because I want to make sure I don't want to put you in a bad spot, but
Yeah.
for a lot of these specifics, as we always say, make sure you check with your
Thank you.
personal physician because these guys are here and they're trying to answer the questions, but I don't want to get him in a spot because he has no idea who you are. So I just wanted to.
Thank you.
Feel free to.
I appreciate that. I'm getting this a lot online now. People want to run by.
Of course, man.
Vaccine questions with their kids and stuff like that. And I'm like, listen, I don't want to be the kind of person who doesn't answer that stuff and gets all legalistic because I that's annoying, right? I want to be helpful, but yeah, if you've got a specific situation, talk to me offline directly about your specific situation or talk to your doctor or somebody you trust who's medical. But in general, I don't think stroke is a reason not to get vaccinated. Just the opposite. We know that this is a disease that causes ischemic events. It causes thrombosis. It causes heart attacks and strokes, as does influenza, by the way. So that's one of the common end pathways to people deteriorating after they get COVID infection. And if you've got baseline risk factors that suggest that your blood flow in your arteries are not good, that's a reason to get vaccinated for most people.
Just another common question. I know we've answered this before, but I know a lot of people are under the impression that there's a test for Delta, but the tests that we take aren't variant specific. It's the test for the COVID. Maybe you can explain the process for some of our newer viewers of how do you eventually determine that it's Delta?
Yeah, so determine what family of COVID a given virus is, you have to genotype it. You have to sequence out the genetic code of the virus, and that's a kind of it's a somewhat more pricey and labor intensive process than the typical test that you get when you go to a doctor's office. So we're not doing that on every single case, and what happens is the Department of Health picks a random sort of subsection of the cases and says, okay, we're going to genotype these to see what the sampling in our population is of different types of COVID. And those are those variant reports that are published on the Department of Health website. So for a specific person, we don't know if it's Delta or Alpha. We just know it's SARS-CoV-2. But if you look at those variance reports on the DOH website, you can see the epidemiology changing month to month to month. And at this point, it's almost all Delta. So when they do those samplings and they genotype them, what they're seeing is Delta, right? And I could have told you that even before reading the variance report, because the thing just got way more contagious and way more nasty and way more explosive right in front of me. And it was obviously behaving different. So I think what we have now is Delta in almost every case.
Okay.
I believe the state conceded to that. They basically came out several months ago and said, based on the sampling, it was pretty close to 100% Delta.
Yeah.
Delta two supposedly is a little more transmissible. They just haven't seen enough data to determine whether or not it's more dangerous. But it does appear to be more transmissible, though. That's what I
Yeah.
just read today.
Yeah. And they should continue to do these variant reports and track these things because it may change. It's not inevitably going to stay Delta. One place that does a very good job of this is the UK. And the American government has been criticized for not doing enough genotyping. So, the higher percentage of cases that you genotype, the better data you have on what's going on and what's changing. And, we're relatively poor at that. As you guys recall, back in like February, March, we were barely doing any genotyping. And now we're doing it better than we were, but we're still kind of lackluster. And in particular, with breakthrough cases and with severe breakthrough cases, I personally think we should be doing almost all of those to make sure that we're not seeing something new.
Okay, Doc. How do you think we can control future pandemics? Do you think some of these viruses could be prevented if we cared more for our environment? Say, example,
Yeah,
global. So, what's your comment on that?
yeah, no, I totally agree. In the first chapter of Plague Doctors, where I'm talking about emergence, I put up a figure and I'm talking about why viruses evolve and why infectious diseases evolve. And a big part of it is the effect that we're having on the environment. It's population growth, it's environmental degradation, and what this does is it just creates more opportunities for humans to interact with microbes, right? Because you're moving into natural habitats, you're disrupting natural habitats, and then you're leaving those disrupted natural habitats and then returning to crowded urban centers and whatnot. So there's just a lot that we do in modern life that creates opportunity for things to emerge. And one way to think about it is that this is sort of nature resisting us a little bit. That if we overgrow our natural habitat and we begin invading other habitats, that we're going to encounter things that push back against us. And I think that might be too moralistic a way to think about it. I'm not sure I would endorse that view entirely, but one way to think about it is that because we've been disrupting the environment so badly, we've created our own enemy here. And one of the things we have to do is think more carefully about the effect we're having on the environment. If we don't want to be in a situation where we're constantly having to deal with emerging infections. So in that first chapter, I talk about the pace of emergence, and what we've seen in the last several decades is that we're finding things more often than we were before. Some of that might just be because we're better at looking. The tools for finding things have become much more powerful. But I think it is more than that. It's population growth, it's globalization, it's medicalization, it's the fact that we have more people who are immune compromised living longer, it's the fact that we're disrupting the environment, that we're creating these big urban centers. It's all of these things.
Okay, thank you. Mel?
What are your overall thoughts about? I know we touched a little bit about it at the beginning, but we have this opening up right now, especially on Oahu. The opening up the outdoor stadium thing. I mean, that's 9,000 people in an outdoor stadium. There's a little bit of concern there, but bars opening up till 2 a.m., 100% capacity, and restaurants and arenas and concerts. And is that, should we be concerned about that right now? As I mean,
Yeah.
realizing that the numbers are, they always talk about the low numbers on Monday and Tuesday when we get the weekend. You notice when it's Wednesday, when it jumps back to the 150s, 160s, and the 10 deaths and the 6 deaths, they don't really talk about the case count. But when it's low, like today and tomorrow, they come out about how ready we are to open up. But I'm curious, what's your thought about it? You think we're moving a little too quickly?
I mean, yeah, it goes back to what we were talking about at the beginning. How many non-immune people are there? And we think there's still tens of thousands of non-immune adults. But, maybe more important to me, morally and ethically, when we're talking about these things, is that we still have, lots of non-immune children. We haven't even begun to vaccinate age 5 to 11, which means that the schools are still vulnerable, right? So I think people are going to disagree about when is it safe enough to reopen. And I don't want to, pontificate about what the exact level of safety needs to be. But for me, what I would like to see is that we continue to do smart things to try to control the epidemic, at least until we get kids the opportunity to be vaccinated. Because if we're not protecting the schools, then what are our priorities? Where are we as a state in terms of our priorities? And, I think you can point out fairly that we've done a pretty good job of vaccinating adults. And with the introduction of vaccine mandates, I want to give the city and county of Honolulu in particular some credit, because I think they did get their vaccination rate up higher by doing that. And despite everyone acting like they were Nazis, or not everyone, some people acting like they were horrible people for doing that, nothing bad happened to those people who got vaccinated. It did help control the infection to some extent. So they have done some good things. But when you're saying, okay, it's our priority to have bars open until 2 a.m., let's say, but we haven't gotten kids in school vaccinated yet, well, that's a choice, right? And we can all evaluate the wisdom of that choice. And my own evaluation is that it's not right, that the kids should come first. And then the question about when is it safe enough to do those things, I think at some point it is a philosophical question or a moral question. All I can say as the MD guy who's in touch with the epidemiologists is I think we still have the potential to have an increase in cases, probably a fairly substantial increase in cases. And as someone who's got a kid going to school, I would like to see my kid have the opportunity to get a shot before it's party time at the bars at 2 a.m. I'm more worried about stuff like that, like the big indoor gatherings, especially the late night indoor gatherings, than I am about people outside, especially if the people outside are vaccinated and if there's some kind of mask enforcement. I'm less concerned about that. So we can talk about relative risk of different activities, but the indoor alcohol serving activities are going to be particularly tough.
Okay. So, Doc, let me ask you this question, and this pertains to our children again. So, do you know of, or have you seen, can't be seen, but I guess what I'm trying to say is because the vast majority of our young ones are not vaccinated,
Yeah.
what is their ability, should they become infected with COVID, to generate enough viral load to really create damage and spreading, say, in an indoor environment? What's the possibilities? They being carriers.
I think we're seeing more and more transmission with kids. So when you look at the 2020 experience before Delta, kids were a very small percentage of the total number of cases, and there was some thinking that they were not as likely to get infected.
Right.
And there was also some thinking that they got more mildly ill, which is still the case. They do get more mildly ill than adults, right? Most kids do fine. But what we're seeing is that there are an increasing percentage of a large number of circulating cases. So now they're 25% or something like that of the circulating cases. And that was true even as cases were going up. And what that tells me is that with Delta, they absolutely can get infected. They absolutely can transmit. Most of them are not going to get terribly ill. But safety is kind of a relative thing. I mean, we vaccinate kids against influenza, and influenza didn't kill as many kids as COVID did last year. COVID killed something like 500 kids last year. And that's despite schools being closed and everyone masking, right? So now we've got a situation where schools are open and in a lot of the country, mask requirements are being dropped. So if we don't vaccinate kids, we can expect that to be worse than it was last year. So I think there's, their numbers look good in terms of bad outcomes when you compare them to adults, because we've had 700,000 deaths amongst adults. But that's terrible. 700,000 deaths is terrible. Up until last year, we all would have thought that was a massive disaster, right? And now we're like used to it, right? When you compare the kid deaths to a typical flu season, it doesn't look good at all. And again, that was despite a lot of mitigation measures. So I don't want to overhype the problem in children, because I think most healthy kids, if they get COVID, are going to be fine. And what I've said to my own child is, if it happens to you, we're going to support you through it, and you're going to be okay, and you don't need to be scared of it. That said, he's going to get the damn shot, right? As soon as it's available, we're going to do it, because I think the risk compared to historical diseases is relatively high, and the safety data, at least, and we can discuss the safety data for the vaccine in kids. It was just analyzed by the FDA this last week, but it looks sufficiently good to me that I feel pretty comfortable doing it.
So I guess my follow-up to that is, does the body frame weight make a difference in the ability for it to give off as much virus? I mean, does
Yeah,
that come?
I don't think it's so much body weight. There may be some differences in terms of how kids express ACE receptors and things like that. There were some theories about this. But at this point, especially with Delta and with the kinds of viral loads that Delta generates and its ability to stick to human respiratory epithelial cells, this is an infection that can impact all age groups, and we just have to think of it that way. There's no protected age group with Delta infection. And there may have been partial protection against infection prior to Delta, but this is a much more transmissible form of the disease. We're talking about a disease that's double the contagiousness, and there were cases in kids even pre-Delta. It's not like it didn't happen. It just didn't happen as much. I think that's eroding. I think we're now seeing that this is a disease that's finding its way into children increasingly.
Okay, thank you.
I have seen the prognosis with the younger ones able to really deal with this disease much better than the older people. But the question always remains about the spreading. So this child that may not be as vulnerable or susceptible to major illness still has the same ability to spread that same virus. It's not a weaker virus in their nostrils that they may be spreading, correct?
Yeah,
it's not they're not getting sick because it's a lesser dosage of the virus. It's the same virus, just their body's able to handle it a lot better than older people.
and I think we have to be able to hold two ideas in our head. One is that kids can transmit, and that's why when we vaccinate, let's say another 5%, because we get the kids with the vaccine program, that's going to have a benefit for everybody, right? That's going to positively impact the health of adults, particularly vulnerable adults around kids, and it's going to positively impact the health of vulnerable kids that are around those kids that got vaccinated. So we're going to get a herd immunity benefit from vaccinating those kids. Now, that said, that is not reason in and of itself to vaccinate kids. To vaccinate kids, you've got to show that the risk benefit for that individual kid favors vaccination. You don't start vaccinating kids in order to protect adults. You got to show that the disease is bad enough in children that the benefit of the vaccine outweighs any potential risk. And in the FDA document, they presented data from this study that was done with 3,000 5 to 11-year-old kids. So 3,000 kids got the Pfizer vaccine at a reduced dose. So it was 1/3 the adult dose. And they compared that, I think, to 1,500 kids who got placebo. And they showed it was efficacious. They showed it was safe. They talked through all the different adverse effects. Now, the criticism, of course, is going to be, well, that's just 3,000 kids. Is that really enough? So that's it? You're just going to do 3,000 kids, and then you're going to give it to millions of kids based on 3,000 kids? I can already hear those criticisms forming in people's minds. And there's some validity to that. 3,000 kids is not enough to detect every rare side effect. They addended to it an analysis looking at myocarditis, because the most feared complication in older kids and in young adults was this myocarditis issue. And they made some very conservative assumptions about the risk of myocarditis. And when I say conservative assumptions, I mean probably more myocarditis than is actually going to happen. So they sort of painted it black a little bit. And then based on those assumptions, was the reduction in COVID and the effects of COVID worth that risk of myocarditis? And in most, I think in almost every scenario except the lowest transmission scenario, it was. So if people are interested in that, they can read that FDA doc, and I think it's about 5 pages, 25 to 35 or something like that, or 25 to 30 in the FDA doc. And I actually linked to it on my Facebook profile, which is public. So people can go in there and read that for themselves. Do I think it's going to satisfy anybody? No, I don't, because what's going to happen is people who already think that the benefit of vaccination is there are going to do it, and people who don't are not going to be reassured by a model or an analysis like the one that's in that document. They're going to say, oh no, I'm not going to be reassured until you do 50,000 kids or 100,000 kids. And then if we do 50 or 100,000 kids, they're going to say, well, that's only 50 or 100,000 kids. You need to do 1 million kids. And at some point, kids are getting COVID while you're doing these studies. So you've got to make a decision, and then assess how it's working. And I think it's not a decision we're making in a vacuum. We have a lot of experience with adolescents, and it's been stepwise reduced the age. So we now have accumulating experience in that 12 to 15 group and in the 16 to 18 group and those other cohorts that can help guide us.
So I guess you just answered one of the mysteries. So if we were to look between adults and children,
Yeah.
it doesn't matter. They both can spread it the same. I guess it's the conditions in which they're spreading it, whether it's in an enclosed area or if it's out in the open. Correct?
I think that's more important for disease spread,
Yeah,
but I have seen cases, and it's been well described in the medical literature of a kid getting infected at home, bringing it into school, transmitting it in school, or getting infected in school, bringing it home, and then transmitting it at home. So the virus just goes where the virus can go, and
right.
it'll hit whoever's vulnerable. And often the people who get mild cases are spreading it are not the ones who are going to themselves suffer the most. It's the people around them. But I go back to this point with my own kid. I would not give my own kid a shot in order to protect some unvaccinated adult that lives down the street from me. That's not a reason to expose my kid to the risk of any medicine, right? It has to be good for that kid. This is the ethical framework for vaccinating children. Nobody disagrees with this. So this is why they're trying to do this kind of safety data analysis and incrementally step it down so that, for example, they looked at all the common side effects, the injection site reactions, the fever, the chills. It looks like it's a little bit more mild in this age 5 to 11 group. It was about 20 to 30% got those types of symptoms. I think less than 10% or around 10% got fever. It wasn't that bad. And then, I looked at things like, okay, were there any serious neurologic side effects? Did anybody get a seizure? Did anybody have any kind of, bad event like that? There wasn't in that 3,000 group data set. So since they didn't find anything bad, then they did this theoretical analysis looking at myocarditis, assuming that the rate would be something like 1 in 5,000 and that they just hadn't seen it in those 3,000 kids. It may be lower than that. It may be 1 in 40,000. We don't know, right? But they assumed a higher rate. And then they looked at, okay, how many kids are we going to save from COVID, and how many are going to get seriously sick from myocarditis? And what I would suggest is people should read that for themselves, and make of it what you will. It's in there. There's no cards underneath the table. It's all out there, right?
His name is Jonathan Dworkin. Go check him out on his Facebook page. You can get. I think you said you posted the study up on your page.
Yeah, yeah, you might have to scroll down a couple, but I try to put the FDA stuff up there because it's the data that they use to make these decisions and recommendations. And I don't think people should just like accept it because some talking head on TV says it. You should read what the people who are making the decision are reading. It's not that much. It's 30, 40 pages. And if you're the kind of person who's deeply, deeply concerned by this, read it. It's 30 pages. You can read it. It'll actually put you to sleep quite nicely. I do it before bedtime. And then I pick it up in the morning and finish it.
Two more questions, I promise. This one is pretty common. Is a person who caught COVID months ago and still unvaccinated today more easily to catch COVID again than a vaccinated person?
Yeah, we think so. And again, there's variability. When you're naturally infected, you might have a really robust immune response, but you might not. It just depends what your situation was. When you get a vaccine, we know exactly how much mRNA we're giving you. You're going to get this much spike protein. You're going to get this range of antibody levels. It's well controlled, and that's how we have good data on the immune response. Naturally infected people, it's the jungle, right? So some people may get a little inoculum, some people may get a big one, some people may have a very brisk immune response or not. And the data suggests that if you're naturally infected, on average, you're more likely to get a reinfection at some point. And I've seen different estimates of how much more likely. But that's why what I've been telling people who are naturally infected is get at least one shot afterwards, and that'll give you sort of equivalent protection. And if you're severely ill, you may have a better immune response, but you may have gotten severely ill because there's something wrong with your immune system. So I would still get the shot.
My daughter's doctor told her should be twice as likely to catch it again if she didn't get vaccinated.
Yeah.
All right, last question of the night. This is fun. I think it's a funny one. What are the main reasons unvaccinated patients give you for not getting the vaccine?
I think at this point, it's changed with time. I think at this point, the vast majority of adults are vaccinated. So the ones that are not, that I'm seeing, most of them have fallen under the sway of some kind of misinformation online. They're not all bad people. Most of them are good people. Some of them are really not. Some of them are really like jerks and yell at me and scream at me and are very conspiratorial and legalistic and nasty. But the vast majority are good people, and they've fallen under some kind of misinformation spell. And oftentimes they'll quote a source to me that is seemingly legitimate. And I don't look into all of them because it was driving me crazy. But when I have looked into them, a lot of times they're physicians, which is kind of sad. So if you look at the AMA data, something like 95% of physicians have been vaccinated. So if you were a betting person looking at the behavior of actual physicians, you would get vaccinated immediately. But there are a few percent of physicians that have not, and some of them are very vocal, and they can be very persuasive, and they're online. So there are people that have found these physicians. A lot of them are non-physicians, but they claim expertise. They may be PhDs, they may be scientists, and they're putting stuff out online that alarms people. And then I've got to try to refute that with the patient. So most of my interactions now are with hospitalized patients. So if you're hospitalized and you're unvaccinated, clearly things have not gone well, and you're questioning your decision tree a little bit, right? So a lot of these people are open to having a conversation with me about what can we do differently to make sure this doesn't happen to you again or to somebody in your family, and those are often good conversations. But if they haven't been infected and they haven't really seen the inside of our hospitals or the inside of our ICUs, they may have illusions about it being a very mild disease. And this is one of the most common things I've run into is, only 0.2% of people die. Well, 0.2% of the United States died in the last year. So that's despite us doing everything we could to control the infection. We still had that large mortality event, and we don't think 100% of the country got infected. Maybe 30 or 40% got infected. We also have really good ICUs in the United States that kept a lot of people alive who would have died in previous generations. So this is not a benign disease. The fact that we've been able to keep, the death toll to only 700,000, which is not a low number at all, is an indication of the level to which we've disrupted society and the absolutely heroic effort, particularly of ICU doctors and ICU nurses, to keep people alive. And a lot of these people that are surviving are not in great shape. So it's a bad disease, and you know, a lot of people are under the illusion that it's not, and that's one of the propaganda hooks that they lure people in with. Oh, you're going to do all this stuff just to avoid a disease that has only killed 700,000 people. And if you actually stop and step back and you examine that, it doesn't make a lot of sense. But it sounds convincing. So people get sucked in that way, and then they get fed, a lot of safety concerns about the vaccines. And no matter how many times this stuff gets proven wrong, this is one of the hallmarks of vaccine misinformation, is that they claim it's going to do something horrible, and then the horrible thing doesn't happen. And then do they acknowledge that they were wrong? Never. They just shift the goalposts a little bit. Oh, well, we just haven't seen enough cases yet, or you're not counting correctly, or just wait another 3 months, or wait another 6 months. And this is not unique to COVID. This is a hallmark of vaccine misinformation with every new vaccine that's come out, right? And what's interesting to me is when the vaccines actually do cause bad side effects, which does happen on occasion, that doesn't get as much attention. So I thought, for example, the rare blood clotting thing with Johnson & Johnson would be something that the anti-vaxxers would latch onto, but they didn't, because it was only 1 in 100,000 or 200,000 people that were having that problem. But occasionally we do see real side effects, and that also doesn't seem to have any impact on their narrative. So mostly it's falling under the sway of experts online, and I don't know what to do about that. Just one conversation at a time, And we have to have some sympathy for these people. Most of these people are good people. They're trying to do the right things for their families. Most of them. I really think that's true.
Yeah, I think you're right. I've watched many of those videos that's been sent to me, and it is. 95% of the doctors in the country are vaccinated. That, to me, like you said, if I was a betting man, I'd go with 95% of the doctors go. I really would. I really would.
Yeah.
But
and then the question is, what's going on with those other doctors? What is the personality phenotype? I have a personal theory about this, and I hesitate to wade into it too much, but we all can think of examples of bad interactions we've had with physicians, right? We all have in our own personal background that one physician who was a total jerk to us or totally unempathetic, that gave us sort of a bad taste in our mouth. And if you think, what are the qualities of bad physicians? I think one personality flaw that may be overestimated a little bit amongst physicians is a kind of narcissism. We all know the grandiose physician who thinks he's God and drives a Corvette and is trying to go out with a girl that's 20 years younger than him. This is a type, right? And it's a traditional kind of phenotype. It's not all physicians, of course, but I think there's a few percent that are genuinely narcissistic and think that they're smarter than everybody else, right? And that may actually be adaptive when you're in a really competitive educational environment like medical school, for example, and it may select for that a little bit. But I find that when I talk to anti-vaccine physicians or physicians who have gotten into that space, a lot of times what they're signaling is that they know something that everybody else doesn't know, that they're special and that they figured this out, and that the rest of us are just being dismissive of their very serious concerns. And there's a kind of self-delusion there, right? Because it doesn't matter how much evidence you present to refute it, they don't accept it. These people can have a very damaging impact. And one of the conversations that we've been having in private is, well, what do we do with physicians that are hurting public health? And it's a tough one. Nobody wants to try to silence legitimate debate. And yet when you're misleading people into doing things that are more likely to get them killed, I think we have to take that very seriously within the profession. This is sort of a self-policing question. So what do you do with a bad cop, right? We all know that it exists, right? So how does that work out?
Got it. Well, I hope you guys enjoyed tonight. That hour went by quick. I know we went a little bit over time. I do want to, Dr. Dworkin, if you enjoyed what you heard tonight, Dr. Dworkin has a book out, Plague Doctors, How Hawaii Battled the Pandemic. And it is available on, oops, where did it go here? I got to go back here. Sorry. It's available on bookshawaii.net just go check it out. I can post a link later tonight on my page. 1995. It's an awesome book. Go ahead and you can pre-order it. I got a little bit. I got this pre-read a little bit, but go ahead and check it out. Pre-order it. It's his story about how Hawaii handled the pandemic from day one. He kept a lot of good notes. So if you guys wanna, I'll put the link up later tonight. Go check it out. How's everything going? Oh wait, how come now? What's going on here? I need to get. Oh, hold on. Boom. There it is. I'm still learning this. What's going on? Oh, I know why. There. All right. I was sharing my
We're
screen.
back.
Anyway, any closing thoughts, Doc, for our viewing audience before we shove off?
No, I appreciate the opportunity to be on, and yeah, I'm excited about the book. I think it's shipping in December is when the main copy gets printed. So if you ordered it a few days ago, you could get it in mid-November. But yeah, I'm pretty excited about it. It's the story of being a doc when this all hit, and trying to tell the perspective from physicians and nurses. So this community's been great, and I think we need to stick together because we're not done with this thing yet.
Yeah, it's called The Village. The Village. Charles.
Well, I'd like to say thank you to our good friend, Dr. Jonathan Dworkin. For many out there, it's always interesting to hear what he has to say. But like you said, you folks need to just do some research too. It's very easy to do. Talk to your own physician, and you can get guided that way. I do want to promote a safety measure that I found to work, and here it is, right here. Snickers, Snickers. Okay, you get a chance, you'll be satisfied. So once you get that on board, anything's possible. Thank you.
Bye, Charlie. See what I can do? I can kick him out anytime I like with this new platform. It's so cool. This guy is. He must have been in heaven last night with Halloween. He must have. He must have. Must
I'm
have
trick
been
or
in
treating in
heaven.
your neighborhood, Charlie, next year.
No, I
I
tell you, last night, wife and I, we were ready. We spent a couple $100 in candies. Not one kid. So guess who has the candies now?
We went out. We did the whole thing. We were in Honokaa looking for houses, and there weren't a whole lot. There weren't a
Right.
whole lot doing it, but it was important to me to get my little guy out there. And we just did it. We were outside. We didn't get real close to anybody, but I think it's fine to do outside stuff like that.
Yeah.
well, we no one came to our place last night. I did get a couple of calls from people on the west side that said their kids got their Snickers ripped off from their little Halloween buckets.
Oh my
It
god.
was yeah. I don't know who, and I'm not even going to say what the description was because I think that'll kind of you all will figure it out. But Charlie, that was not cool. Anyway, folks, thank you for joining us tonight. I know we're a little bit late. Tomorrow night we got Dr. Miskovich and Dr. Akiona again. He's going to chime in on what's happening mostly in Honolulu with the opening up. Dr. Miskovich and many of our experts are concerned that we may be moving a little quickly. So they'll be on tomorrow. Wednesday night we have our will and estate workshop, free will and estate workshop for all of you. I mean, a doctor. Ward Jones, attorney from Brevard and Jones out there in Oahu, will be presenting. Please join us on Wednesday night. And then on Friday, we have Dr. Tim Brown from East West Center. He'll be on to share his knowledge and expertise on what's been going on. So it'll be a jam-packed week. I appreciate you guys coming in. We love you guys. You guys all stay safe. Stay safe. Remember the village. We gotta be cover each other's back, guys. In a village, we will get through this. All right. Take care, you guys. God bless.
Mahalo.